My name is Joe Gill. I'm one of the faculty in the hand division at University of Orthopedics. The patient population I take care of primarily ranges from various trauma injuries to various athletic injuries and nerve compression and nerve injury problems. Today I'll be talking to you about cubital tunnel syndrome. I'll talk about the symptoms that show up with this diagnosis, how we diagnose it, and how we take care of it. So let's get started here. Again, cubital tunnel syndrome is nerve compression of the ulnar nerve at the elbow. We'll talk more about the anatomy of the ulnar nerve, what cubital tunnel syndrome is exactly, and what causes it, and how we diagnose it, and how we take care of this problem, both non-operatively and operatively. So ulnar nerve compression, also known as cubital tunnel syndrome at the elbow, is the second most common peripheral nerve compression problem after carpal tunnel syndrome. Incidence is 21 out of 100,000 person years. Patients are oftentimes more likely to show up with a more severe presentation than carpal tunnel syndrome, given that there's less awareness about this condition. And because that, patients tend to put it off more, or simply just patients that don't complain of a similar type of problem as to some symptoms, so it doesn't get picked up on early where it gets diagnosed and treated. So a little bit of the anatomy of the ulnar nerve here. It's highlighted here. I don't know if you can see my arrow here. If you look at the small finger, that yellow structure that passes by the elbow, and it goes up into the shoulder. And you can see how if irritation of the nerve at one point can send symptoms up and down this nerve, and this is where patients can complain of radiating symptoms. Typically, it's radiating symptoms down from the elbow down into the hand to the small and ring finger. This is just a more detail of the kind of pathway of the ulnar nerve as it goes from the upper arm through the elbow into the arm, through, again, what's called the cubital tunnel at the elbow. And this cubital tunnel here, as you can see, is made up of the ligament that comes across, called the Osborne's ligament, and the floor is basically the bony anatomy of the ulna and the distal humerus. As the ulnar nerve passes down into the hand, there's a second source of potential compression at the Guillen's canal, which is located at the small finger side of the wrist. And here you can see just in this diagram the various compression points, potential compression points of the ulnar nerve in the hand, and this would come with various symptoms depending on where it's compressed, whether it's just sensation deficit, where the hand is numb in the small ring finger, or if there's grip strength issues plus sensory deficit. And we'll get into that a little bit more in a little bit here. So the critical sensation of the ulnar nerve is the small finger and the small finger side of the ring finger. Here you can see in this figure. And importantly, the ulnar nerve also provides sensation to the top of the hand. And this will serve as an important finding or important kind of feature on exam. If this is absent, then it will suggest that the nerve is being irritated at the elbow. However, if this sensation is still present, along with some sensation deficit on the small finger side and the pad side, then that would suggest that the ulnar nerve is being compressed at the wrist. So compression points at the elbow include various compression points up at the septum between the front and the back of the arm, up in the upper arm. As you go down further, the common compression point is the cubital tunnel at Osborne's ligament. And as you move on even further into the forearm, the nerve could be trapped in various kind of tight bands of tissue as the nerve passes into the flexors of the forearm, the different muscles of the forearm here. So the problem with nerve compression is that really it's a mechanical problem that disrupts the blood flow to the nerve coating. And the coating, you could see here, this is a kind of cross section, or if you cut the nerve and look at it, you can see it looks almost like a cable that goes to your TV. If you cut it, you look down, you see the wires inside. Here, the coating, unlike the TV cable, is a live structure. And as the nerve is compressed, the coating has a difficulty kind of remodeling and getting the nutrition it needs to stay healthy, and eventually that coating breaks down, and internally similarly have different changes that happen as a result of the compression that lead to delayed conduction of the signal through the nerve, which patients initially feel as numbness and tingling, and that later progresses into weakness and muscle loss. And again, when patients show up to the office, patients often talk about diminished sensation in their small and ring finger, and typically they feel like if it's coming from the cubital tunnel, like it starts at the elbow and it feels like they hit their funny bone all the time, and that's where the nerve is irritated. But again, in the hand, they feel like that small finger and ring finger, and as those symptoms are oftentimes ignored initially, the muscle starts to diminish in strength, and patients show up with different symptoms of weakness. They find that it's difficult to clip their fingernails because of decreased strength in that pinch, and then loss of fine motor skills. And additionally, sometimes patients complain of sharp pain that shoots down from the elbow down into the hand, and that's again specifically related to cubital tunnel syndrome. So on physical examination, really a lot of the early stuff is limited to just the sensory deficit that could be picked up on when patients complain of numbness and tingling. In the office here, we assess each finger and find that the pattern of numbness is specifically localized to the ulnar nerve, which again is the small finger and the radial side of the ring finger. And that'll clue us into the ulnar nerve being impacted. And the nerves can be irritated at the, again, cubital tunnel, at the Guillen's canal at the wrist, or even in the cervical spine. So even though this is a finding that's associated with this nerve compression at the elbow, we think of other things when we see this, but at least it clues us into cubital tunnel as a possible culprit. Here you could start to see where the arrow is showing muscle atrophy. This is again a later finding, kind of more correlated with severe cubital tunnel syndrome. And if this is happening, again, care should be sought out immediately, because again, once you get to this point, really the options become limited, and as soon as you start to get more and more atrophy, the likelihood of a successful outcome is more limited compared to early on. So just a couple other specific examination findings that we see with more severe cubital tunnel syndrome. Again, this is similar to that muscle wasting. These are things that we see kind of again in a severe presentation, where the time to intervention must be more urgent than just kind of waiting it out and seeing how things go. And in these circumstances, as we'll talk about later, the non-operative management is less likely to be successful. So the first is the Wartenberg sign. You see that small finger kind of floating away from the rest of the hand. And that's because of the muscle between the small and ring finger, called the interosseous muscle, is not working properly. So the finger starts to float away, and you see this Wartenberg sign. The second thing you see here is a Frohman sign, is where instead of having this normal pinch, as you see on the right in this figure here, you start to see this kind of abnormal pinch where you're flexing through the tip of the thumb, and then you're using your index finger in this way in this flex posture, because you're using a different group of muscles to recreate this pinch, because you can no longer pinch the normal way, because the interosseous muscle, the muscle between the two, the thumb and the index finger, is not working properly. And finally, claw hand is again one of the more end stage features, and again, this is again more serious finding related to the imbalance of the muscles around the small and ring finger, resulting in this claw posture. And again, if you have these type of symptoms, again, important to get evaluated rather expeditiously, so the diagnosis is known. So maneuvers that we use in patients with less obvious ulnar nerve deficit, you tap the nerve at the elbow, and again, you get that funny bone sensation. I think again, normally patients, if you hit your ulnar nerve at the elbow by accident, you'll get that funny bone feeling. But this is more extreme, where you're getting it with any type of irritation back there. You put your hand on the table or bump it against something. You have zingers on your ulnar nerve. It's way more sensitive than it needs to be. That's a positive test. Some patients who, if you bend their elbow up and hold it there for 30 to 60 seconds, that causes numbness in the small finger. With the elbow flexion test, that could provoke that ulnar nerve symptom and kind of clue you into diagnosis of cubital tunnel syndrome. And finally, if you combine these two things and compress the nerve and flex it, that's usually the most sensitive at picking it up if the nerve is irritated at the elbow of the cubital tunnel. One other feature of cubital tunnel syndrome and just ulnar nerve anatomy and at the elbow is its stability. So about 37% of patients in general have ulnar nerve instability. It's not an issue until it starts to develop irritation and ulnar neuritis, where you start getting numbness and tingling and weakness. But a lot of patients can live with it. It's important to feel for this and examine for this on exam, because if it is unstable, it really changes what you want to do with surgery. You wouldn't do a simple surgery, just release it and leave it unstable, because that will leave the nerve in a situation where it's less likely to heal and recover if it's not stabilized during surgery. So oftentimes, once you suspect ulnar nerve problems on exam and history, one of the first things that we do test for is that we get an electrodiagnostic test to look for the health of the nerve by looking at the velocity at which the nerve transmits the signal. So if we start to notice some delayed signal, or where it's slow compared to when it's normal, then that's when we suspect the nerve being irritated. And the nice thing about these tests, which are done by our colleagues here, we could detect where it's being irritated, whether it's the nerve at the elbow or at the wrist, or if there's some cervical problem associated with it. I tend to obtain a lot of ultrasounds in my patients, because I think, as you can see in this study here, it does really correlate to what you're going to find intraoperatively, so there are no surprises. They could help me prepare patients for surgery instead of just saying I might move it. In patients that are very unstable, I'll plan to move it this way. They could have the proper expectations for the incision and recovery from a surgery standpoint. So grading systems, as we discussed, we kind of focused on the mild and the severe. The mild will typically come with sensory disturbance, and the more severe will come with those exam findings we discussed, whether it's the Frohman or the Wartenberg or the atrophy signs. And the ones in the middle are kind of at the point where you're starting to notice weakness with pinch and some subtle atrophy that would kind of lead you to diagnose the patient with more of a moderate type of cubital tunnel syndrome. So it's important to think about other things that could result in elbow pain or numbness and tingling, including things like cervical spine problems, like a disc herniation or degeneration of the cervical spine. You could have things like thoracic outlet syndrome, where the nerves get compressed beneath the collarbone or in the armpit areas. They transition from the neck into the arm. In patients with severe elbow pain, it's important to consider things like golfer's elbow and arthritis. And then similarly, in patients with wrist pain, it's important to consider things like tendonitis and various fractures. So my first, when I meet patients initially, typically with either mild or moderate symptoms, the go-to treatment protocol is to proceed with night splinting and activity modification. So what that looks like, the night splint is a splint that basically keeps your arm straight. And we know from prior studies that with the arm straight, the tension on the nerve is decreased over nighttime to help get the blood supply back to it, to help it recover and heal, so to speak. And oftentimes patients notice an improvement in the numbness and tingling. And to me, the successful splinting is when the numbness and tingling resolves entirely, and with just the splinting at nighttime. And I oftentimes combine activity modification with this, where I ask patients to avoid putting direct pressure on the elbow, whether it's how they lean on a table, or avoiding repetitive tricep strengthening at the gym, where you're really forcing that elbow into flexion extension. And again, avoiding periods of time where you keep the elbow flexed at all times, like in patients who work at the computer all the time. We try to have them work in an extended position or take frequent breaks. So in up to 90% of patients, particularly with the mild symptoms, report some relief at 6 months after beginning splinting. And again, the probability of requiring surgery at 1 year after conservative management is about 80% in the mild, so about 20%. About 20% in the mild, where 80% have persistent relief at 1 year. In the moderate, it's about 33% that fail splinting and need surgery. And again, in the more severe cases, we oftentimes try the bracing, but at about 70% tend to fail this and require surgery in 1 year. So in the severe, we tend to lean towards surgery when we see those findings, just because we know it won't be successful long term. And there's a window there. So once the muscle starts to atrophy, it's less likely to recover if we wait too long. So treatment options have been a little bit all over the board over the last couple of decades. I think historically people, surgeons will tend to do a more comprehensive dissection of big incision, but multiple studies, like well-designed studies over the years, have shown that you could do an effective release through a small incision behind the elbow, what's called an in situ release or a simple decompression. And here in this review of 4 big studies, they found that patients had similar relief and outcomes. And this is important because if you have no real difference from a clinical standpoint, it's important to consider which surgeries can give you less morbidity or less complications. And we find that with the in situ release or the simple release, that the surgery is much easier to recover from, particularly in the first couple months, with less likely to have complications like hematomas and pain and different having nerve irritation just from the surgery alone is lower likelihood of that with a simple decompression. Having said that, I think that when you do have to do a bigger surgery in situations where patients have a more severe presentation, or if they have an unstable ulnar nerve, the study also shows that by 8 weeks after surgery, that kind of risk profile or complication profile goes down to an equal level between the 2 techniques. So I think, again, in patients who have a more simple presentation, doing a simple in situ release is my preference. But again, in those more severe presentations with extreme atrophy, where you're considering to augment your procedure with nerve transfers, or if the nerve is unstable to begin with, I tend to do a transposition. Again, these are just the list of the benefits of the in situ or the simple release, that it's easier to do, easier to recover from with less complications and a faster recovery. So that's it from just the overview of the cubital tunnel syndrome and the way we diagnose it, from the physical exam to the electrodiagnostic testing to the ultrasound. That's just an overview of this in situ release, which is my preference at this point, given it's a relatively quick recovery. In a couple of weeks, patients are pretty much pain-free from an incision standpoint and are on the way to recovery from a nerve standpoint. And then I think that there's still a role for the more extensive operations where we move the nerve from the back of the elbow to the front of the elbow. In those cases where patients present with severe atrophy, or if they present with an unstable nerve to begin with, I'd like to do the bigger surgery. All right, so just some questions coming through on the chat. So first one is, how long does the procedure take? So with the in situ or simple decompression, that could take anywhere from 5 to 15 minutes or so. But basically, as long as it takes, I think that even through the small incision, we could encounter tricky things like an accessory muscle that we have to work through to get down to the nerve carefully. So we take our time in those circumstances. But again, I think whatever time it takes to get it done safely, but it does not take too long. The second question coming through here is, where is the surgery done? We do the surgery both at the East Bay Surgery Center here in East Providence, or at Rhode Island Hospital. Either way, just based on whatever works from your timing standpoint and for your schedule. How long will I be out of work? That's a good question. I think it varies from patient to patient. I think for some patients who do primarily clerical work and kind of have a relatively light load of work as far as from a physical standpoint, patients go back to work pretty quickly, even in the postoperative dressing that same week if they're up to it, from my experience. Other times, patients prefer to wait till their sutures come out at about 10 days after surgery. And in some patients who do construction, they tend to be out a little bit longer, closer to the 4 to 6 week mark. It just all depends on kind of how much demand you have from your occupation. And I think if we end up ultimately doing a transposition where the nerve has to go move to the front for various reasons, whether it's instability or the severe nature of the problem, that could take a bit longer. So if we transpose it could take closer to 6 weeks before patients feel like they've overcome the incisional transposition healing. and then another week or two after that before the strength comes back. So it is a bit of a bigger recovery. And then, pretty much, any other, I think, the hard thing is, with this problem is that, as you get the sense here that the ulnar nerve can be compressed at different locations, whether it's the cubital tunnel, which we talked about today and focused on, or the Guillen's canal at the wrist, or this could be related to a cervical spine problem or compression, underneath the collarbone and thoracic outlet. So it's important that if you do have these symptoms of numbness and tingling with a small ring finger, I think it's important to come to a hand surgeon or upper extremity specialist, get evaluated. We're happy to see you in the office, do an exam, make a plan specific for you and your problem. You can figure out where it's coming from and make a plan specific to you. So thanks for your attention, and if you have any questions, please feel free to reach out to the office. We're always happy to see you.